I'm going to introduce Dave. He is a clinical psychologist and associate professor in the Substance Abuse Research Division at the Wayne State University School of Medicine in Detroit, Michigan. He's also the director of the Problem Gambling Clinic at Wayne State and the secretary of the Michigan Association on Problem Gambling. So without further ado, Dave, it's all yours.
Thank you, Robbie, and thanks, Mordo Chappelle in North Carolina, for having me back again. Really happy to be here. I will give a plug to Mark Lefkowitz, who's going to be doing the 12-step presentation. He is great. He really knows his stuff on 12-step, and I've trained with him many times in the last decade, and he's a really engaging speaker on the topic. So I think that would be a really great talk. Today, I'm going to talk to you about motivational interviewing and cognitive behavior therapy for gambling disorder. Now, given that we have less than an hour to cover this topic, this is just going to be a survey, a kind of an overview of the topic, the effectiveness of these types of interventions, and also some of the main principles behind them. You'll probably notice as I go through this talk that I have a lot of slides, and hopefully you've received the note pages for these slides. It's entirely possible through this presentation I might go through some of these slides rather fast, some of the ones that are maybe less important. But if you ever have any questions about the presentation after the fact, my email is right there at the bottom of this slide. So it's my first initial D, last name up to the W, so D Ledger W at med, like as in medical, .wayne.edu. So if you ever have any questions, you can feel free to send me an email. I'll be happy to answer them. We're going to jump in right now, and I'm just going to minimize my picture screen here so I can see my slides as I'm going through here. Just a few things to consider as we're going through these slides and this presentation on motivational interviewing and cognitive behavior therapy, to ask yourselves. I know that most, if not all of you, are clinicians who treat people with gambling problems, and most clinicians have sort of different perspective on therapy. Some people are more into evidence-based therapy. Some people consider therapy to be more of an art and more of a sort of an interpersonal experience, and aren't necessarily as into evidence-based therapy. So I wanted to consider, what are the most effective treatments for gambling disorder as far as you're concerned? What treatment approaches do you use or do you ascribe to? Is there a difference in outcome between evidence-based approaches and treatment as usual approaches in your experience? Do you use evidence-based approaches? And if not, does that matter? You just consider these questions as we go through this presentation. I think it will be useful, because we're going to talk about the two approaches that have probably the most evidence in terms of their effectiveness for treating people with gambling problems. They've also been applied to substance use disorder and so forth. But I'm going to sort of talk about it in terms of gambling problems. So before we get too far, I want to present to you very briefly a study that I was involved with back about 12 years ago, when we published it in Journal of Consulting and Clinical Psychology. And this was a study that involved people with gambling problems, not necessarily people with gambling disorder. Some of the people in the study did have gambling disorder, but for the most part, it was people who had sub-threshold gambling problems. So they had some symptoms, but they didn't meet criteria for gambling disorder. We had 180 participants in this clinical trial. There were problem gamblers recruited from among patients at community medical and dental clinics and substance abuse clinics. So they weren't actually in gambling treatment. And it was a type of clinical trial we call an intent to treat analysis. And what this means is we intend to give the treatment to everybody that's in the study, but we follow them up regardless of whether or not they complete the treatment. So if someone is in a group where they're expected to have 4 therapy sessions, but they only completed 1, we still follow them up to the end of our long-term follow-ups to make sure that, to see if there are any changes or differences between groups. So these 180 folks who were recruited from these various clinics were actually randomly assigned to one of 4 treatment conditions. It was a brief intervention treatment. So they were either sort of sent to an assessment-only condition. There were about 48 people who were in the assessment-only condition, a brief advice condition, where they just received 10 minutes of brief advice to stop gambling or reduce their gambling, motivational enhancement or motivational interviewing group, where they received one 50-minute session that was focused on motivational interviewing techniques and helped to bolster a person's sort of motivation to quit gambling or reduce their gambling, or a fourth group that was a 4-session group, 4 50-minute sessions, where they received one motivational interviewing or motivational enhancement therapy session, followed by 3 cognitive behavioral therapy sessions, which we'll talk about a little more in depth as we go through. And as you'll see, we assess them at the beginning of treatment, and then we assess them after 6 weeks and after 9 months. This slide very quickly just shows that people were primarily in their 40s. They tended to be slightly more men in the study. They tended to be just about 2/3 white or European American. They were making about $25,000 a year, and they tend to have high school or a little bit more education. In terms of their gambling symptoms, for those of you who are not familiar with some of these acronyms, the NODS is a lifetime measure of DSM-4 pathological gambling criteria. So that measure goes from 0 symptoms up to 10 symptoms. A score of 5 or more would suggest diagnosis of pathological gambling. So you'll see that most of our folks were, or on average, they were right at the cutoff for pathological gambling, which means we had some that met diagnostic criteria and some that were a little bit below. The South folks gambling screen, dogs, their scores were a little bit higher, which we do expect, even though 5 is the cutoff for gambling disorder. They were gambling about 16 to 19 days per month and spending somewhere between $300 and $500 per month. They were primarily doing scratch-offs, lottery tickets, slot machines, and playing cards. And as you'll see here, as you remember, there was one attendance-only group, and then there were 3 treatment groups. And 2 of the treatment groups, the brief advice group and the MET group, only had one possible session that they could attend. We found that almost everybody attended at least one session, regardless of the groups that they were in. You'll see that the MET plus CBT group actually could attend up to 4 sessions. So they would have an initial motivational enhancement or motivational interviewing group. About 88% attended that first group. Then they had cognitive behavioral sessions after that, up to 3 additional sessions. And you'll see about just over half attended the first one, and just about a third attended all of the sessions, all the CBT sessions. When we looked at the differences in their problem gambling severity scores, and this is based on a measure called the Addiction Severity Index gambling screen, we found over time, first of all, at the very beginning of treatment, everybody was sort of grouped together in terms of their gambling severity. They were all pretty much the same. But we also see that if we look at the various groups over time, we see that the folks unexpectedly who are in the 10 minutes of brief advice group reduced their gambling severity scores to a greater extent than did any of the other treatment groups. So the assessment only group, the motivational enhancement session, or the MET plus CBT group. When we go out to 9 months, we see that some of the folks in the brief advice group actually kind of rebounded to be similar to the MET and the control group, where the MET plus CBT group was doing a little bit better. So some unexpected results and some somewhat more expected results here. So we didn't expect the brief advice group to be doing better after 6 weeks. And we did expect the MET plus CBT group to be doing better after 6 weeks. Our other data are a little bit more clear and also unexpected. We see here in terms of mean dollars gambled per month, and this is a log transformed value, so this doesn't actually correspond to dollars on the left-hand side of the graph. We see that it's the brief advice group that actually did best both at 6 weeks and at 9 months. Well, this is really quite unexpected. And we definitely thought that these evidence-based treatment approaches of motivational enhancement and motivational enhancement plus cognitive behavior therapy would do better than the 10 minutes of brief advice. And this is a little bit of a sort of a caveat in terms of trying to understand the effectiveness of such interventions of motivational interviewing and cognitive behavior therapy is it depends on who you're working with. So remember, in this case, these were people who are non-treatment seekers. They were primarily people with a fairly low number of problem gambling symptoms. They were not interested in treatment. If we had actually asked them if they wanted to go to treatment, they would have said no. But they were willing to do a few sort of brief sessions with us. And the briefer the session, the better, apparently, in this case. When we redid this study with college student problem gamblers, we got a very different result. In that case, we found that the motivational interviewing plus cognitive behavioral group did better than all of the other groups, and the brief advice group didn't do very well. So regardless of what we think about evidence-based treatments, cognitive behavior therapy, motivational interviewing, and so forth, there are a lot of factors that go into whether or not they're any better than anything else. And that's something that we need to consider when we're thinking about who we're treating and how we're treating them. These folks had lower education, they had lower employment, they were making less money, they were engaging primarily on scratch-offs and so forth, where the college students were engaging in cards with friends, they were more educated, potentially had more money coming in, and so forth. So there's a lot of differences between groups. Very briefly too, I also wanted to sort of highlight a recent review, fairly recent, 2017 systematic review of all of the treatment studies that have been done up to that point, behavioral treatment studies that have been done with people who had gambling problems. And this was conducted by Nancy Petrie, who is at University of Connecticut, and Carla Rash. Unfortunately, Dr. Petrie passed away a couple of years ago, but she was very well known in the problem gambling field and had done an enormous amount of work in this area in terms of psychotherapy, and I had the opportunity to work with her for several years. She did a review of all of the studies that have been done thus far in terms of clinical trials, and these are sort of good quality clinical trials that have been published in sort of the peer review literature and scientific journals. And as of 2017, she basically was able to identify only 21 studies. So there were only 21 clinical trials looking at behavioral treatments for gambling disorder. But that's not very many, especially considering that we've been doing this work since probably back in the 1980s. And unfortunately, it is a sign that there's not a lot of funding out there to be doing problem gambling research. And the studies tend to be from all over the world. They tend to be some from the United States, several from Canada, several from Australia, some from the UK, and some from other parts of the world. And for this particular study, non-English articles were excluded, but there's really not that many outside of the English world. So again, only 21 studies. And what she basically found here was there are basically 5 types of studies that have been investigated in high quality clinical trials in the problem gambling treatment world. Cognitive treatment, cognitive behavioral treatment, and I'll try and get into what the difference is between those two. Motivational interviewing or motivational enhancement approaches, self-directed approaches like using workbooks or other types of self-directed approaches, computer-based, that sort of thing, and brief feedback or brief advice types of approaches like the one we saw in that first clinical trial that I mentioned to you. And some of the conclusions of their review, I think, are quite important for us going forward in terms of understanding what do we mean by it when we talk about evidence-based treatments, when we talk about treatments that have evidence for effectiveness or efficacy. And what they found was that the evidence for the efficacy for different treatments for gambling disorder is quite inconsistent across studies. And it's also true that the quality of those studies is inconsistent. So we know that cognitive behavioral approaches have the most evidence for efficacy or effectiveness. And we also know from the research that has been done thus far that motivational interviewing and motivational enhancement approaches alone don't seem to be very efficacious, but they seem to be more efficacious when they're added to cognitive behavioral approaches. And one of the things that you'll find as we sort of talk about MET and CBT is that usually we tend to use motivational types of approaches for therapy up front in the first sessions, and then transition into a cognitive behavioral approach so that we can first start to address the ambivalence that a person's bringing about their gambling, and then move into coping strategies and other sort of approaches to address cognitive distortions and so forth. Brief interventions seem to be modestly effective, but they also seem to be best for people who generally don't go to treatment. So in our study, you'll notice that we recruited people who didn't meet criteria for gambling disorder, so they couldn't go into other studies or other treatment programs. But we had a number of people who did meet criteria for gambling disorder. And one of the things that we did with those folks was we asked them if they wanted full treatment for gambling disorder, and we only took people who declined. So people who said, no, I don't want to go to treatment for my gambling. Then we followed up with, well, how about this brief intervention program? It's only 1 to 4 sessions, and it's a sort of a brief intervention. A lot of folks decided to take us up on that after we explained what it was.
Hey, Dave.
So, yeah, Robbie? Yeah.
Quick question. And I'll admit too, I've got this question as well. Someone has the difference between efficacy and effectiveness. Yes. Is there a fine line there? Yeah.
It's not even a fine line.
Okay.
So efficacy trials tend to be studies that are done in a rather controlled sort of setting. So for example, back at University of Connecticut, when I was there, we had several clinical trials. A lot of the trials that we were talking about actually came out of that lab, where we have very specially trained therapists who are working in a university research laboratory, and we recruit people with certain criteria. So in this case, either problem gamblers or people with gambling disorder, to come and be treated by the people that we have trained and hired and so forth. And then we look at the data, we compare the different treatments. So it's a very sort of controlled environment. We're at a university setting, all of the therapists work for us, we control the training, we listen to all the sessions, we rate to make sure that the sessions are being done right, and so forth. Effectiveness trials are more when we try and transfer those interventions to the community and to community-based providers. So for example, we've conducted some of these studies in substance abuse treatments using something called contingency management, where we went into a number of treatment centers and we trained the treatment centers providers to actually do these interventions, and then we monitor them to make sure they're doing it right. But we take a step back and see if this can be done in like an actual real life community-based setting. So that's in a nutshell the difference between sort of an efficacy trial and a community effectiveness trial. What I will say about that is the vast majority of the studies that have been done thus far are actually efficacy trials. So they've been done in more tightly controlled university types of settings, and there are relatively very few community-based effectiveness trials out there. So hopefully that answers your question.
Very good question. Yeah, good question. Yeah.
Really good question, actually.
Yeah.
Really.
Yeah. So, thank you, Susan.
When we're talking about that, this sort of goes into these issues to consider. We're talking about sort of some of the conclusions of this review. The authors essentially said, when we're considering the effectiveness or the intervention or the efficacy of these interventions, you have to consider a lot of things. You have to think about what's the patient population, because some patients will benefit from behavioral or brief interventions, and some will actually benefit more from, say, motivational interventions or more cognitive interventions. Most people do want face-to-face therapy, but the types of therapy we provide and the duration and that sort of thing may depend on the population that we're looking at. Long-term effects are really not that well known. We don't know if treatments actually, for example, improve on natural recovery in the long term. So, for example, one of the things we do know from gambling treatment is only about 1 out of 10 people with a gambling disorder will ever seek out any sort of treatment. But we do know that the vast majority of problem gamblers who recover from gambling disorder do so without any type of treatment whatsoever, including any type of 12-step support. The outcomes are all over the place. We've never really looked at the difference between a treatment focus on abstinence only versus harm reduction or controlled gambling. The comparisons between interventions are difficult because a lot of the interventions are different in terms of exactly how they're done, the manuals they use, the duration of the sessions, the number of sessions, and so forth. And no studies have actually looked at co-occurring disorders, like, for example, the role of depression in clinical trials, or substance use disorder and that sort of thing. We haven't looked at those things yet, and the likelihood is that we're not going to for the long term, because there isn't enough sort of funding out there to actually do that kind of research. Those are all the caveats. Now, with all that said, I really like motivational interviewing. I teach motivational interviewing, and I feel like regardless of the level of or degree of evidence within the gambling disorder, there is evidence that it helps bolster cognitive behavior therapy. We know from the substance abuse literature that it's also a very effective treatment. Although I would also say the substance abuse literature is also quite mixed. So there are previous studies, early studies looking at motivational interviewing, for example, compared to 12-step facilitation and cognitive behavioral approaches that found very few differences between those approaches. But there are a number of other studies that have found differences. I'm going to talk very briefly about sort of the beginnings of motivational interviewing. It was developed by Bill Miller and Stephen Rolnick. And it was primarily initially used with people with substance abuse problems who are oftentimes not only sort of coerced into treatment, for example, maybe through the justice system or other things, but what we're with clients who are described as resistant or unmotivated to actually change their substance use behaviors. And now after literally hundreds of treatment trials, we found that it's effective in substance use disorder treatment. And now it's being applied to numerous other health and mental health problems. For example, health screenings, sexual risk behaviors, HIV risk, diabetes control, medication adherence, and many, many more. And the idea of motivational interviewing is it helps move people in the direction of reducing sort of their ambivalence, reducing resistant behaviors, increasing adherence to medical advice, and lowering attrition in treatment. I will say that a lot of motivational interviewing is actually based on a Rogerian style, which is more of sort of a experiential, it's non-directive, it's about helping people to get a better understanding of their motivations and their experience through reflection, through non-judgmental questioning of the person's experience. A lot of motivational interviewing comes from that background, but it's different in that that sort of Rogerian perspective is really not a very directive approach to treatment. Whereas motivational interviewing, motivational enhancement, as we sort of talked about, is much more directive. It's directive in that the goal is in the direction of recovery and enhancing recovery. But it is also a very client-centered approach and a client-centered method for enhancing intrinsic motivation to change by exploring and resolving ambivalence. So in this sort of brief statement, directive client-centered method for enhancing intrinsic motivation to enhance motivation to change by exploring and resolving ambivalence, I think there are a few things that are important here. First, directive. It's directive in the direction of leading towards recovery. It's client-centered, so it's focused on clients' needs, wants, motivations, affective state, so forth. But the two, I think, really important pieces to this statement are the elements of intrinsic motivation. So we're eliciting or evoking a patient's or client's motivation, and we're also trying to explore that motivation within the context of ambivalence. So with anybody who's in substance abuse treatment or anybody who's engaged in anything for that purpose, for that matter, is going to experience ambivalence. So for example, for any of us who might be thinking, I'm not in the job that I want to be in, and I'm thinking about maybe moving to another job, we're going to be ambivalent about that. So we're going to think, well, what are the pros and cons of staying in the job I have now? What are the pros and cons of going to the other job? It's very rare that one is a slam dunk decision. We're going to experience ambivalence. Well, we're going to experience ambivalence in almost every area of our life. So it's not a surprise that people with gambling problems or substance use problems will also experience that ambivalence. It's more of a style than a type of therapy like CBT. It's not just a bunch of techniques, but it's a way of interacting with clients. Like I said, it's client-centered, so it involves listening to the client, reflecting, trying to understand their experience. It involves empathy, putting yourselves in the client's shoes, and it's goal-directed. And when we're thinking about motivation, for those of you, I think pretty much everybody on the call probably knows the stages of change. You can see here the stages of change listed from pre-contemplation to maintenance. We like to think that change happens in a straight line, that we start not believing we have a problem, then we come to some enlightened state where we realize we do, and then we make a bunch of changes. We engage in action, we change those behaviors that we need to change, and then we end up living our lives, becoming self-actualized, growing, all of those things that we really want to do. But in reality, change happens in a really messy way, something like this, or any other pattern that you want to choose. We tend to recycle, we tend to relapse, we tend to go back and forth in terms of our motivation as to whether or not we even have a problem. And that's true of anybody who comes to see us with a gambling problem as well. I've certainly experienced times where I've had clients come in and they've had, they want to change everything all at once, and they did. But there's always something there that someone's ambivalent about. I can remember a guy I saw some years ago who came in to our medication-assisted treatment clinic, and he was using heroin, he was using cocaine, he was drinking, he was smoking cigarettes. He came in all gung-ho about recovery. He stopped using all of those substances. He joined a smoking cessation study that we had going on and stopped smoking cigarettes. And he was doing very well in terms of substance use. But he was also working with a PhD student doing therapy. And one of the things he was highly ambivalent about was opening up emotionally. He wasn't able to sort of talk about the hurt he was experiencing, the anger he was experiencing, the sadness he was experiencing over recent relationship failures. And of course, in working with this PhD student, I'm like, this guy is going to kind of crash at some point. Can you work on him trying to open up? And eventually, it did all come tumbling down on this guy, and he ended up relapsing to the smoking, relapsing to all the substance use. Luckily, we didn't lose him. We got him back in, and this PhD student engaged him again and said, why do you think this relapse happened? And he was able to sort of address his ambivalence about dealing with the emotional sort of aspects of his recovery. And once he was able to get a hold on that, he was able to actually go back to the progress he was making before. He stopped using drugs, he stopped smoking again. And several years down the road, I happen to know that he's a peer support counselor, and he's doing actually really, really well. So if you think about ambivalence, ambivalence doesn't have to be just about the addictive behavior itself, but it has to be about, often is about other things that might also be sort of related to the addictive behavior. So the overall goal of motivational interviewing is to increase intrinsic motivation so that change arises from within rather than being imposed from without, and so that change serves a person's own goals and values. This is sort of echoes what we've already talked about in terms of the previous quote that I gave you, but it's really important to focus on some elements of this. So this idea of intrinsic motivation, change arises from within rather than being imposed from without. I work a lot with PhD clinical psych students and with psychiatry residents who are trying to learn how to do psychotherapy. And one of the things that they struggle with mightily is this idea of, I'm frustrated because I know that if this person will just do X, Y, and Z, their life will be so much better. But when I mention that to this patient, they just don't end up doing it. And almost invariably, I'll come back to them and say, well, what do you think if instead of you telling them what they should do, you get them to tell you what they think that you should do? Do you think they'd be more likely to follow through? And they all agree that that's probably true, but they also agree that that's really difficult to do. So this enhancing intrinsic motivation so that we're evoking, and evocation is an important term here. I'm going to use this term a fair bit, that it comes from within rather than being imposed from without, is really important. Because if a person believes that it's their goal, their value system, their objective to do something rather than having someone tell them to do it, they're more likely to do it. So that's important to know. Now, Miller and Rolnick, I'm going to kind of talk about some elements of what they laid out in terms of various aspects of motivational interviewing. I'm going to go through this somewhat quickly, but you guys have the slides, so you can kind of revisit the slides if you need to. I want to make sure we cover at least some motivational interviewing and some cognitive behavior therapy today, because it's challenging to cover everything in 1 hour. But in terms of motivational interviewing, Miller and Rolnick talk about the spirit of MI. And there's sort of 3 key elements to the spirit of MI. And I'm going to talk about them just really briefly. The first one being collaboration. And the idea behind collaboration is that the therapist approaches the client as a partner, like a consultant. It's not sort of a doctor-patient relationship. It's not where the doctor says, hey, I think you should do X, Y, and Z. I'm prescribing this to you, and that will make your life better. In this case, the therapist is helping the client to explore, and the therapist is using sort of more of a supportive style, a way of sort of getting a person to open up by using more of a, like I said, a consultation type of approach. Evocation is that term that I just used a couple of minutes ago, and evocation is really, really difficult. It's eliciting or drawing out motivation from a client. So drawing on the client's own goals, perceptions presumed to reside within a client. So this is where I talk about the power of your interventions as a therapist being much greater if the sort of the impetus for change and the direction of change is coming out of the client's mouth as opposed to your mouth. So if you can get the client to talk about what they need to do to change their direction, then that's going to be much more powerful than if you're telling them. So we call that evocation, so eliciting or drawing out that motivation from a client. And this is really challenging for a lot of therapists who want to just sort of say, I wish you would just do X, Y, and Z because things will be better. If you just took your meds, your symptoms would decrease. If you follow through, I know you haven't experienced any changes yet, but if you just give it 1 or 2 more weeks, maybe things will be better. That's all great, but it's not a motivational interviewing style. And one of the ways that I tend to sort of focus on this evocation is I will ask clients to tell me, what are the most important things in your life? What are the things that you value? What are the things that you want to be successful at in your life? A lot of people will say, well, I want to have a family, or I want my marriage to be strong, or I want to be a good dad or mom, or my career is really important to me, and I want to be successful there, and all of these things. And then you can start to ask people, so tell me about the problem that you're experiencing with the gambling, with the drugs, whatever. How does that fit with these values that you just shared with me? It's a great way to get people to start talking about their behavior within the context of their motivation. It's, in terms of the evocation. And of course, a respectful approach, which, on the face of it, of course, we're all respectful to our clients. But when we're talking about respect within a context of motivational interviewing, what we're talking about is the fact that all responsibility for change lies with the client, not with the therapist. So if the therapist is starting to find that they're doing all the work in a session, that they're providing all the insights, that they're providing all the advice for change, that means that something has gone amiss. All of the responsibility for change lies with the client. All of the autonomy is with the client, and the client is free to accept or not accept your counsel. Now, this is not talking about situations where the client's life or safety or the safety of someone else might be in jeopardy. That's a different thing. So suicidality, all of that stuff is not what I'm talking about. What I'm talking about here is if a person wants to continue to gamble, it's up to them. The consequences are theirs as well as the behavior, right? Your role as the therapist is to point out the differences between the client's behavioral sort of responses to things, and their values and the things that are important to them, so that the client can then make an evaluation of why they want to change or why they don't want to change. There are specific guiding principles of motivational interviewing, and I'm going to talk about these very, very briefly. Empathy, of course. So what we want to do is accept where the client is at. We want to try our very best to put ourselves in that person's shoes. And one of the things that we need to really sort of realize here, and once you sort of acknowledge that we're all ambivalent about many, many things in our lives, is this idea that ambivalence itself is a normal state of being. I would say ambivalence is just a state of being human, right? We're ambivalent about many things in our lives. So for me, on a very superficial level, when my alarm went off at 6:30 this morning, I was ambivalent about whether I wanted to get up or just hit the snooze button for 20 minutes. That's ambivalence. It doesn't have a lot of consequences, but it is ambivalence. Now, of course, again, I'm not going to go through sort of empathetic style, but this is here for you guys to sort of look at. What I do want to focus on this idea of developing a discrepancy, because this is something that's a really powerful intervention that's really useful when it comes to working with people with addictions generally. Again, all argument for change should come from the client, not from the therapist. And change comes from a discrepancy between present behavior and important goals and values. So as I talked about, exploring a person's values, their life goals, and so forth, gives you as the therapist an important sort of library of information about your client that helps you to sort of frame questions where the client has to think about something that's discrepant. So for example, you have somebody who is coming into your office and says, "Doc, I just blew another $1,000 at the casino, and I've got 3 credit cards that are maxed out, and I'm worried that the bank is going to start calling my house because I'm overdrawn on these accounts. But I'm worried that my wife is going to find out, and I'm not sure how to address that. I don't know if I should tell her or if I shouldn't tell her." But the client has already told you that it's important that he has a strong marriage. So as a therapist, you could come back and say, I would really like to figure out with you how you're going to decide what you're going to do here. Because on the one side, you're telling me that you're worried about your finances, you're worried about how your wife is going to take it, and you're considering hiding it from her. But on the other side, you're also saying that you want to have a stronger, more trusting relationship with your spouse. So when I put it that way, what do you make of it, right? So again, you're developing a discrepancy between a person's values and their potential behaviors, and you're putting back to the client and within a non-judgmental way, in a gentle way, in a matter-of-fact way, and saying, what are we going to do here? What do you think we should do with this, right? Now, we do this in part because we want to get people to move away from the status quo. So the status quo is what keeps people gambling, what keeps people using. And we use terms like change talk, which is talk that the client sort of engages in, which is a sort of an indication that they're moving in the right direction. They're moving towards more of a recovery orientation, compared with sustained talk, which is more the status quo, sort of staying the same. So for example, if someone comes in and says, I really don't feel like I have a problem. I don't know why I'm here. My wife is making me come in here. That's sustained talk. If a person says, I really don't feel like I have a problem. My wife is making me come here, but I feel like I do need to at least do something because it's important to me that my wife and I have a good relationship. That has a mixture of some sustained talk, but it also has a good dose of change talk. And a therapist can kind of look at that and even just reflect that back to the client and say, so what I'm hearing is, on the one hand, you don't feel like you have a problem, but on the other hand, it's affecting your marriage and you really don't want it to affect your marriage. You want to do something about it. That moves people in the direction of talking more in the direction of change talk as opposed to this sustained talk. And so when you're developing these discrepancies, helps to challenge the client in their inconsistencies between their behavior and their actual goals and values. I can't stress enough that I think developing discrepancies is one of the most powerful interventions in motivational interviewing. The other thing a couple of things I'll focus on very briefly is avoiding resistance, avoiding arguing for change, avoiding, resistance from a client is not to be directly opposed. You can put new perspectives out there, but if the client sort of says, "No, that doesn't work," you shouldn't keep hitting on that nail with that hammer. You should say, "Okay, so that sounds like it's not a real good fit for you. What do you think would be a good fit? What does describe this? What we're talking about?" So resistance is a signal to respond differently as opposed to confrontation. A confrontational approach is not motivational interviewing. And then supporting self-efficacy. So this belief that change is possible is actually a motivator. Oftentimes we'll ask our clients first, on a scale of 1 to 10, how motivated are you to change your gambling behavior? And let's say someone comes back with a 5. Well, we might come back to them and say, "Oh, a 5, that's interesting. How come you set a 5 and not a 3 or a 4, right?" So we're essentially saying, why is your motivation that high and not lower? As opposed to going the other way and saying, "Well, how come you're not a 7? All these bad things are happening to you." That tends to make people sort of close up and sort of be more resistant, be more defensive, and so forth. You go the other way, they become less defensive. Well, it's similar with self-efficacy. We could sort of ask a person, let's say if they're trying to quit smoking, for example, and they've already said that their motivation to quit smoking is pretty high. We might say, well, on a scale of 1 to 10, how confident are you that you can quit smoking right now? And let's say someone says 5, right? Sort of middle of the, well, let's do even lower. Let's say someone says a 3. I'm not sure, I'm not very confident that I can quit smoking. Well, the therapist could go, well, what will get you to a 7? But that might be overwhelming to a client, right? Instead, what if a therapist says, well, then a 3. So what made you say a 3 and not a 0 or a 1? What is it that's driving that 3? And it's not sort of lower than that. That gets people to start talking about the elements in their sort of thinking where they do believe they may be able to engage in the behavior, right? We can apply that to smoking, we apply that to gambling, we can apply that to other substances of abuse. People come in, they may want to change their behavior, but they may feel like they can't. So if someone gives you like a 3 out of 10, you could say, well, you did say a 3, you didn't say a 0. So what are the things you're thinking about when you say a 3? And that might be things that you can do, right? So it's important to support self-efficacy through those sorts of questions as well. I'm not going to go into the basic methods today, but just suffice it to say that these are really important and they're not as easy as they look. Engaging in open-ended questions, engaging in affirmations, so letting people know, for example, it's great that you've come in today. It's a big step to come into therapy. Sounds like you really know what you want. It sounds like you're working hard to maintain your relationships, even though they're not going so well for you. You want to be able to support a person by validating them. So affirmations, reflective listening. So when we talk about reflective listening, we might be talking about repeating back what a person has just said to you. But I think more importantly, it's reflecting back what a person means and what a person is feeling and what a person's sort of affective experience is. Summary statements are more longer, sort of more summaries of reflections of what a person is saying to you, but also eliciting change talk. And so you'll notice that I have a number of slides here that are for your use. And if you have any questions about them, I'm happy to sort of come back to this. But I want to sort of jump ahead because we only have this 1 hour to talk a little bit about the next step. Oftentimes from a motivational interviewing approach, we move into a cognitive behavior therapy approach with people with gambling disorder. And a cognitive behavior therapy or cognitive therapy approach, really what we call it sort of depends on what our emphasis is. So you'll remember with that review, Nancy Petrie's review, I talked about cognitive therapy and cognitive behavior therapy. Cognitive behavior or cognitive therapy focuses primarily on cognitive distortions around gambling, on sort of distorted thinking. Cognitive behavior therapy includes those discussions of cognitive distortions too, but they also have a larger focus on behavioral components such as reinforcing non-gambling behaviors, or encouraging problem solving, or social skills, or relapse prevention, and so forth. So when I talk about CBT or cognitive therapy, I usually focus a little bit more on, use the term CBT, because I think that encompasses more things. So we talk about cognitive therapy involving understanding beliefs that relate to gambling, to learn how to evaluate objective evidence that supports or contradicts the gambling beliefs, to learn how to develop healthy alternative beliefs related to gambling. And for those of you who have had some training in cognitive therapy, you'll know that Aaron Beck was one of the major um, pioneers of the development of cognitive therapy approaches, particularly for depression, for anxiety disorders, for other sorts of mood disorders. And Aaron Beck's approach to this was sort of focused on these ideas of core beliefs, intermediate thoughts, and automatic thoughts. So, Judith Beck is actually Aaron Beck's daughter, and Judith Beck has sort of taken on the mantle of cognitive therapy from Aaron Beck, and a great book that she has called Cognitive Therapy Basics and Beyond has a few good quotes in it. One, in a nutshell, the cognitive model proposes that dysfunctional thinking, which influences the patient's mood and behavior, is common to all psychological disturbances. We're talking about sort of mood disorders and so forth. We're talking about sort of tunnel vision. We're talking about dysfunctional thinking. We're talking about things that maintain a negative mindset. We also know we can apply this to addictions. When people learn to evaluate their thinking in a more realistic and adaptive way, they experience improvement in their emotional state and behavior. We often think of a cognitive triad as sort of the interrelationship between a person's perceptions of themselves, their experiences, and their futures. And this sort of graphic shows what a cognitive triad might look like for someone who is depressed or anxious, generally has a lot of anxiety, or is experiencing a lot of negative consequences of addiction. And just to go through the cognitive model of Beck's cognitive model very quickly, we have basically three levels of sort of cognition. At the very superficial level, at the very bottom, are automatic thoughts. They're just words, thoughts, emotions that go through our minds at any given situation. And at the top are beliefs. They're the most fundamental of belief, and they're more globalized and they're overgeneralized. And there are thoughts that we have about our world, ourselves. They're sort of deep-grained thoughts. In between those are what we call intermediate beliefs, and sort of the rules, attitudes, and assumptions that we essentially live our lives by, and that inform our automatic thoughts and are informed by our core beliefs. Our automatic thoughts and all these other sort of belief models are also affected by our life around us, our environment, the situations we get into. And so, for example, if we have a close call with another car on the highway, we have to honk our horn, our automatic thought might be, wow, what a bad driver. And you might be pissed off. You might be angry at that. And your reaction might be to feel bad about it for the next half an hour. Your reaction might be to laugh at what a bad driver that guy is. Or hopefully not, your reaction might be road rage, right? But ultimately, whatever your reaction is going to be affected by your core beliefs, your intermediate beliefs, and these automatic thoughts. When we move to more of an addiction model, we often think about sort of work that actually came out of the substance abuse world. And this is a quote actually by Kathleen Carroll, who is a psychologist at Yale University. And she's one of the pioneers of cognitive behavior therapy for substance use disorders that has been actually moved and adapted to gambling disorders. So a lot of the work by Petrie and so forth is based on Kathleen Carroll's work. Very simply put, and I'm going to substitute the word cocaine for gambling for cocaine. Very simply put, CBT attempts to help patients recognize, avoid, and cope. That is, recognizes the situations in which they're most likely to gamble, avoid these situations when appropriate, and cope more effectively with a range of problems and problematic behaviors associated with gambling. So the idea here, I think the important words are actually capitalized here, is to be able to recognize those situations, high-risk situations, triggers, so forth, to avoid those situations when they can, or to cope with them when they can't avoid them. that's basically CBT in a nutshell for a gambling disorder. So in addition to understanding how our thinking works and how our thinking is informed, it's also about putting this into practice and trying to understand how to recognize those thoughts, recognize those situations, avoid those situations, or cope with those situations. And this graphic that I'm showing you now was actually created by Katie Witzkowitz and Alan Marlatt. Alan Marlatt, who passed away some years ago, was the pioneer of a substance abuse cognitive behavioral therapy model called relapse prevention. And many of you have probably heard of that particular model. But he came up with a really great graphic. And I think I'm going to end on this graphic because we've got 5 minutes left after this, and I want to get to your questions. But the idea here is that anyone who's in a high-risk situation, high risk related to their gambling disorder or their substance use problem, will either cope effectively with that high-risk situation or ineffectively with that high-risk situation. So someone who is doing well, who is psychologically doing well, is effectively doing well, who has a lot of coping strategies, may have an effective coping response, so the upper arm of this graphic. And that might result in increased self-efficacy, so an increased belief that, hey, I can cope with this high-risk situation, which should very well lead to a decreased probability of relapse if a person is experiencing a risk situation and they're not using currently. On the bottom line of this graphic is the sort of idea of this ineffective coping response. So if someone is overwhelmed, they don't have the tools to cope with this high-risk situation they're experiencing, they may experience a decrease in self-efficacy and also positive outcome expectancies around their addiction. So what this basically means is they feel like, well, if I just have that first puff of a cigarette, it'll help me unwind and I won't feel so stressed, right? It's positive outcome expectancy. Then there's the initial either use of a substance or engaging in gambling. And then we experience something called an abstinence violation effect, which is just a fancy way of saying, I blew it. So you feel like down on yourself, you feel like, that's great, I just screwed up everything. And then perceived positive effects of using the drug or engaging in gambling. So well, if I just have another cigarette, I can be stress-free. Or if I just go to the casino, then I don't have to think about all this for a while. And then there's, of course, an increased probability of relapse. I like to use this graphic with my clients, actually, because they really seem to get it. This idea of if you cope well with a high-risk situation, you decrease your chance of relapse. If you can't cope well with it, you increase your chance of relapse. And I especially like to do it with my clients who are abstinent, but they're still experiencing a lot of problems, because I've had many folks over the years who might get 2 weeks into no gambling, and then they have a really bad day. And it only takes one bad day to make you feel like crap, because you lapse, and then you experience this sort of this bottom rung of this particular graph. But if you can teach people effective coping strategies, then that might simply be restricting the amount of money you carry with you so that you can't gamble, right? Something like that. That could actually really help. Now, I'm going to stop here. I have a number more slides. I do want to just focus on the idea of triggers. I want to just point out this last slide, which is about functional analysis, where you start to use this, you can use this graphic to teach people about these thoughts, these situations, the behaviors they engage in, and the consequences. And oftentimes with gambling, there's some sort of stressor that leads a person to feel bad about themselves, feel upset, leads to gambling, and the immediate consequences tend to be positive. So I can gamble and forget about that argument I had with my wife, but the longer term consequences tend to be a lot less positive. They can be quite negative. So things like, the next day I feel like I'm a failure, I lost $2,000, and so forth. So I often use this graphic as well to start to teach people the patterns of their thinking and their behavior so that it's more real to them. So I'm going to stop the presentation there. Again, you have the slides for the additional information, and I'll just open it up to any questions in the last few minutes.
Yep. Hey, thank you, Dave. Yeah, we'll have the slides in the recorded version on the website. I've had a couple of questions. I've chatted you folks, so yeah, don't worry. They'll be on tomorrow, maybe even this afternoon or tomorrow or Monday, Tuesday. And Dave, there's been a few great questions. One that I want to get to here. I told Susan I would get. Uh, she asked about, is the dysfunctional thinking that causes causing the behavioral issues? Is it true that like depression, is it caused by genetic disorders?
Well, depression or addiction for that matter is caused by many different factors. From a cognitive perspective, that perspective focuses mostly on distorted thinking patterns. So,
Mm.
Judith Beck would probably say that people get depressed because, first of all, their experience sort of leads them to think in such a way that is sort of negative, is focused on the self and the future and one's prospects and one's abilities and so forth, and tends to be very narrow, like very sort of tunnel visiony, right? And also unwaveringly negative, right? But there are, of course, biological underpinnings to depression, right? In terms of genetic underpinnings. But there are also people who have genetic underpinnings for depression who recover from that in part because they change the way they think. And we also know from the research literature that cognitive behavior therapy works as well as medications in terms of alleviating some of the symptoms of depression. Does that make
Gotcha.
sense?
Yeah, yeah. Thank you. Thank you. And by the way, guys, we're at 1 o'clock. If you have to go, thank you for joining us. And please remember to join us August 6th, again, with the grandfather of gambling training, Mark Lefkowitz. And as Dave said, I've heard his 12-step talk. It is great. And he's been doing this since what, I think the mid 80s, right, Dave, or even early 80s. But he's got
Absolutely.
great stories. And
I was trained with him in 2009 with the California group. It was really good. Mm.
yeah, yeah. So he's really good. And but anyway, so August 6th, go to the website to register, and thank you. Dave, if you don't mind staying on a couple minutes, uh, just got a couple
No
more
problem.
questions. Susan has another question, which I think was great. It was during the motivational interviewing segment, and she asked, would it be appropriate, I believe it was when you were talking about empathy, what what would you
Mhm.
advise me to do if I were in your situation? If the client asks you that, what, from your experience, how do you,
Absolutely.
yeah,
Absolutely.
that's a
Because
good
that will
question.
help people. When people, especially like when people are experiencing a level of hopelessness or sort of helplessness around their experience, the way they approach something like that might be different for themselves than it would be for a friend or a
Mm,
relative, right? If someone came to them asking them for advice, they would probably have some advice for them.
yeah.
So that's a great way to ask that question. I think that's wonderful.
Yeah, that was a good one. Barbara asked, what is the percentage of people with gambling disorder who improve without any professional treatment? Do you have any data on that?
I don't have a specific number for you,
Yeah,
but I think people cycle in and out of addiction over their lifetime,
yeah,
and that's not just gambling, but it's also substance use disorders. Like with alcoholism, if alcoholism doesn't kill you, you probably reduce or quit drinking at some point, right?
yeah.
Um, I don't have an exact number for you. I probably could look it up.
Yeah. No, but that was a great question, Barbara. I know personally, I know people who use, of course, the 12-step programs, those who quit cold turkey, whatever addiction, who've gone to treatment, and it's just different things go in and out. I don't, it's, yeah, but an exact number, I wonder if there's any data out there.
Yeah.
And then Susan asked, how many abstinence violations equals a relapse? At what point have they relapsed? So that's kind of like the slip relapse
That's a big.
terminology. Yeah.
Well, absolutely. I mean, it's tricky. About a decade ago, I wrote a paper on gambling relapse, and one of the things that I really found tricky in that writing that paper is defining relapse and what is a relapse compared to like a slip or a lapse or whatever you want to call it. And what I've sort of come down to in terms of the definition of relapse is a return to uncontrolled use of a substance or engaging in addictive behavior. So, for example, if somebody was a cigarette smoker and they weren't smoking, and then they just had one cigarette, and then they stop there, I don't consider that a relapse. That's sort of a slip or or a lapse. But if somebody had a cigarette and then the next day they were back to it, they're back to smoking half a pack a day or more, that would definitely be a relapse. Now, then you kind of butt up against definitions of terms like controlled gambling or controlled drinking or controlled whatever. And that's, I think, a matter of, in some ways, perspective, right? Like if somebody says, I've had a gambling problem, but part of that was because I would go and go to the slot machine all the time, and I'd go and I'd lose a lot of money. But then when they quit doing all of that, they say, well, I'm just going to play poker with my friends once a week, and it's only $20. Do we call that a relapse? I don't know that we necessarily. Some people might, but I don't think I would. And would we even call it a lapse if it's a conscious decision and the person's able to do that without consequences?
Yeah, great
I think it's
answer.
an age-old question that we don't have.
Yeah, and you know what? This isn't scientific, but I use whatever approach works to keep the person on their path to recovery, right? I mean, if whatever term works in that, and keeps him, traction and what they say in the 12-step rooms, willing, so. But yeah, but I get these questions quite a bit in the workshops. Is that a lapse or is that a slip or is that, so, right. But hey, Dave, thanks again for your talk. This was great. And we appreciate you always coming on and hearing your knowledge. You're, a leading researcher in this field, and we're always grateful to have you on speaking. So thanks, and very good.
It's grateful to be on, which is nice. I mean, to have the opportunity to come out. Sounds good.
Okay. All right. Thank you, Dave. And thanks everybody for being on today.
Thanks everybody, and stay safe and stay healthy.
Okay. All right. Thank you.
All right. Bye guys.